USMLE style question on polymyositis. A 45-year-old woman presents to the clinic with progressive muscle weakness over the past 4 months. She has difficulty climbing stairs, rising from a chair, and lifting objects above her head. She denies sensory loss but reports mild muscle pain and morning joint stiffness. She also experiences shortness of breath on exertion. Physical examination reveals symmetric proximal muscle weakness affecting the shoulders and hips. There is no skin rash. Pulmonary auscultation reveals bilateral fine crackles at the lung bases. Laboratory results: creatine kinase CK 7,200 U per liter elevated, aldolase elevated, ANA positive, anti-Jo1 antibodies positive. Electromyography shows myopathic changes with fibrillations and spontaneous discharges. Muscle biopsy reveals endomysial inflammation with CD8 plus T-cell infiltrates. Which of the following is the most likely diagnosis? A. Polymyositis. B. Dermatomyositis. C. Inclusion body myositis. D. Myasthenia gravis. E. Lambert-Eaton myasthenic syndrome. Correct answer A. Polymyositis. Explanation: polymyositis PM is an idiopathic inflammatory myopathy characterized by progressive, symmetric proximal muscle weakness due to CD8 plus T-cell mediated muscle fiber damage. Key clinical and lab findings include proximal muscle weakness, difficulty climbing stairs, rising from a chair, lifting arms, elevated CK and aldolase indicative of muscle damage, anti-Jo1 antibodies associated with antisynthetase syndrome, which includes interstitial lung disease, myopathic changes on EMG, muscle biopsy, endomysial CD8 plus T-cell infiltrates. Why not the other options? B. Dermatomyositis would present with heliotrope rash, Gottron papules, and paramysial inflammation with CD4 plus T-cells on biopsy. C. Inclusion body myositis affects older adults, 50 years, involves both proximal and distal muscle weakness, and has rimmed vacuoles on biopsy. D. Myasthenia gravis causes fatigable muscle weakness, affecting ocular and bulbar muscles first. Reflexes and CK levels are normal. E. Lambert-Eaton myasthenic syndrome causes proximal weakness but improves with repeated use, is associated with small cell lung cancer, and has normal CK levels. Key features of polymyositis: progressive proximal muscle weakness, elevated CK and aldolase, anti-Jo1 positivity suggesting antisynthetase syndrome, interstitial lung disease, ILD, may be present, endomysial CD8 plus T-cell infiltrates on muscle biopsy. Management: high-dose glucocorticoids plus immunosuppressants, methotrexate, azathioprine for long-term treatment. If severe, consider IVIG or rituximab.